Good morning, everyone. I'm talking about cluneal neuralgia as a cause of low back pain and leg pain. Cluneal neuralgia is known as a rare cause of low back pain. There are several anatomical and clinical reports stating that some patients have severe pain due to the entrapment of the medial branch of cluneal nerve. The first report of surgical cluneal nerve release was reported by Mage from France, and he stated that this is a rare clinical entity, and it consists of 1.6% in their patients. And excellent outcome was obtained when entrapment was observed during surgery. And they also said easily treatable cause of unilateral low back pain. The purpose of our prospective studies were to investigate the prevalence of the superior cluneal nerve disorder and to characterize clinical manifestation of this clinical entity. Methods. A total of consecutive more than 800 patients suffering from low back pain and leg pain were enrolled in this study. Our diagnostic criteria for SCN disorders were that the maximally tender point was on the posterior iliac crest, approximately 70 millimeter from the midline, and palpation of the maximally tender point reproduced the chief complaint. So this is an example. And she says, pushing on the iliac crest, reproduced her back pain and also leg pain. So localized, tender point is very localized. Results. So our study showed that cluneal nerve disorders is not rare. It consists of 12% of consecutive cases and can cause not only low back pain and also leg symptoms. And cluneal nerve disorders is often bilateral and severe. When comparing to between cluneal nerve disorder and the remaining non-cluneal nerve disorders, cluneal nerve patients are a little bit older, and back pain is more severe. This slide shows the visual analog scale scores for low back pain and the changes after the local anesthetic lidocaine. You can see there almost half of patients are satisfied with first trial, and the remaining 1/3 required second trial, and the other one required third trial. But you can see anyway. To say substantial resolution of the pain relief. And the patient often shows painful limping. This painful limping continued more than 5 months. This is 4 days after surgery. he can walk smoothly with no pain. Cluneal nerve patients have usually back pain, but half of them have leg symptoms, usually leg pain or tingling. In 19 cases who underwent cluneal nerve entrapment surgeries, 16 subjects had leg pain or tingling. Of these 16 subjects, 10 reported that the leg symptoms were more severe than the low back pain. This drawing is drawn by a patient, and he stated that the low back pain on the iliac crest, and he also had lateral calf pain, and calf pain is more severe than his low back pain. And 14 subjects had leg symptoms spreading from the iliac crest buttock area, and the remaining 2 had leg symptoms removed from the iliac crest. Patients often have a flexion limitation, and this is before surgery. When he flexed forward, leg pain appeared all went down to the calf. So after surgery, he obtained full range of motion. This is a surgical observation, and there are several nerve branches over iliac crest, and arrow indicates the tiny entrapment under fascia. This is a summary of the initial 90 cases I did surgery, and red leg symptoms in letter red shows that the leg symptoms are more severe than low back pain, and patients complains variety of leg area like inguinal, calf, sole, and patient often shows flexion and extension limitation, and some of them shows painful limping, and 2 of them cannot walk. Previous surgery means their past history of surgery, and 6 of them had unnecessary spine surgery, and 1 of them had multiple spine surgery and knee surgery, because these cluneal nerve symptoms mimics spinal disorders or knee disorders. For surgical outcome, average BAS scores and RDQ scores showed significant improvement. And patients with more than 3 days of effectiveness from cluneal nerve blocks, and patients with shorter duration of symptoms, less than 3 years, had a significantly higher ratio of excellent outcome. Patients often shows 2-point tenderness. One is on the iliac crest, and the other one is below the iliac crest. Cluneal nerves, there are 2 cluneal nerves. One is the superior cluneal nerve that is running over the iliac crest. The other one, medial cluneal nerve, that runs below the posterior superior iliac spine. Approximately half of patients have concomitant middle cluneal disorders. We've done lots of anatomical study, and middle cluneal nerve penetrate the ligament below the PSIS. This photo is during surgery, and middle cluneal nerve is running through under the ligament, and there is a severe constriction under the ligament. This lady had a history of herniatomy from other hospital, but there was no pain relief, and BAS scored 100 before surgery. She had limited arc of motion in all directions of the lumbar spine, and she's saying that she cannot extend at all. So this photo is during surgery. You can see middle cluneal nerve running under the ligament. And after the release, I cut the ligament. So cluneal nerves are now released. This video is just after the surgery. So BAS scores 0. So in conclusion, cluneal neuralgia is not rare. This clinical entity may be underdiagnosed and should be considered as a potential cause of chronic low back pain or leg pain. Thank you.
We have time for a few questions.
Very short questions. When you said that you cut the ligament, what is the effect of cutting the ligament as far as what is the negative of cutting the ligament? What the person will lose or not lose?
Some patients complain subtle, instability, unstable feeling in the back, but pain's gone, so they are happy.
So you have subluxation.
Yeah.
Is that
yeah.
a rotational subluxation or a translational subluxation?
I don't know.
Okay. The next question is, what is the clinical exam that you would do in order to say the SCN is the cause of problem? Is there a specific clinical exam that you can do as a physician to isolate that problem?
Just palpate on the iliac crest and reproduce their symptoms. And also, we do repetitive nerve block. Okay? After block, they say the pain's gone. That is our method to diagnose. Yeah. Thank you.
Thank you. I would like to continue on. I think it's an overwhelming result that you are showing there. People that really can go back to life after this surgery. I'm not from within orthopedics or surgery at all, so I'm a PhD, but I have a question about the diagnosis, in continuing to the question that was asked here before. How do you distinguish between this status and for instance, disc herniation that can occur and cause fairly similar symptoms. Was there any imaging that was done, and could that be detected through imaging?
Yeah, and that's a good question. I've done lots of radiological study, like using neuro MR technique, or and also EMG technique, electromyogram technique, but the nerve is too skinny, and it's not possible to visualize, or not to detect any deficiency in EMG. That's why I think so far it's just a clinical palpation and also nerve block. That
So basically, if you don't have any disc herniation,
yeah. Some patients have both. Okay, but how to say? It's sometimes difficult, but we know. I'm a spine surgeon, and I know that, for example, L4-5 disc herniation can cause which areas of leg pain. But these patients have leg pain in different area. So yeah. Thank you.
Doctor, oh, go ahead.
What tissues it innervates?
Yeah.
Would it be
Yeah.
better to cut the nerve
Mhm.
rather than the ligament?
Yeah. I think this is pure sensory nerve around the buttock. Okay. I have some experience of the deafferentation, the cutting nerve, but they say just analgesia in the buttock. But problem, I think, maybe is because I've seen so many patients after bone harvesting from iliac crest. That bone harvest may injure the nerve. Actually, I have several patients. In them, severe pain, it's called CRPS, occurred after bone harvest. That's why I don't want to cut the nerve, okay? But if patient has very long-lasting pain, like 20 years or 30 years, the nerve itself highly damaged, degenerated. So nerve release doesn't work well. So for such a patient, sometimes I cut the nerve. It works very well. Yeah. Thank you.
Thank you. Thank you, Dr. Aota, for good information. So, like my queries there, like for general doctors, like the patient do come to the OPDs, right? So, at what level they can, the clinical side, they can refer to the consultant, right, rather than giving some NSAIDs or doing some like tests. So, which level, what they can do to diagnose this is not sciatica or like that disc displacement or is the cluneal nerve. So, this is how to differentiate from the sciatica sinus symptom and this superior cluneal nerve, right? Yeah, thank you.
Yeah. You mean how to differentiate?
Yeah, like clinical side, general physicians, like before referring to the specialist, what tests they can make rather than overutilizing the resources.
Yeah, I think it's kind of easy. Just palpate around the iliac crest. If it reproduces their chief complaint, it should be clunealgia. If patient sometimes patients with true sciatica due to disc herniation or canal stenosis may have tender point on iliac crest, but they never have the appearance of leg pain when I palpate the iliac crest. Okay, that's a point.
Dr. Aota,
Yes.
I had one more question to expand on yours as well. How do you differentiate from SI joint pain? That's been
Yeah.
a huge issue.
Yeah. Actually, middle cluneal nerve is running near to SI joint. Okay. My hypothesis is majority of SIJ patients or patients that has been diagnosed as SIJ disorders should be middle cluneal nerve entrapment, because several researchers stated that in SIJ patients, nerve block around the ligament works well than intra-articular block. Okay, so the key structure in SIJ disorder is the ligament, posterior ligament, and middle cluneal nerve running through the ligament. Because so far nobody's have surgery of middle cluneal nerve. I think I'm only one in the world to have a release of the middle cluneal nerve, but that works very well. Okay, so and the SIJ disorder is kind of a very confusing, very how to say, difficult to diagnose, and also no radiological study define that entity. So my hypothesis is a majority, or how to say, more than 50% of patients around that patient who has very lower back pain around the buttock must be middle cluneal nerve disorder. Yeah. It's still my hypothesis.
But it makes sense.
We say that cluneal nerve is a sensorial nerve, and it takes stimulus from the buttock. How can we explain the radiation to the calf as it stimulates to sciatica?
Yeah. I've done many anatomical studies, and in the textbook or in the previous anatomical report, cluneal nerves derives from dorsal rami of T10 to L3. But in our study, superior cluneal nerve has come from L4 and L5. So that's why that is referred leg pain. So the brain confused, like L4 or L5 area pain. That's why I think some patients have calf pain, or sometimes they complain pain in the sole.
Okay, thank you.
I think that's all the time we have for questions. If I could ask Dr. Aota to come up here.